Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas, sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes. Thanks for tuning in to the Ultimate Dental Podcast, the podcast where thought leaders, industry experts, and thriving practice owners reveal their very best tips, tools, and strategies that will help you grow your dental practice faster. Now, here's your host, Dr. David Moffet.
Hi, everybody, and welcome to the latest episode of the Ultimate Dental Podcast. I'm your host, Dr. David Moffet in New South Wales, Australia. And today I'm talking with Dr. Alain Aubé, who is in Montreal area in Quebec, Canada. And we've just been marveling how he's on yesterday's time and I'm on today's time. But that's just how the world is. And Alain, welcome to the Ultimate Dental Podcast. Thank you for being a guest.
Thank you, David, for having me. It's a pleasure, of course.
Well, it's great to have you, Alain. And you came across my radar in talks with the advancedbyce.com platform that I've been working on. And that's because you have a distinct specialty in dental practice, and that is an interest in occlusion. And you're also an occlusion expert, and you've also designed and patented your own occlusal splint. So, Alain, let's talk about your journey from dental school, or even before, if you wish. How did you get into dentistry? What made you focus on occlusion? And what's brought you to where we are today?
Okay, that can be a long answer. Let me try to keep that story a little bit short for you. Okay, always had an interest in the medical field. I was 3 years old. I told my dad I'd fix his little divot in the chin when I would be old. So I always said I wanted to be a doctor of some sort. So that was always in there. When I got to college level, at first I wanted to be a neurosurgeon, but then I found out I graduated around in the mid 30s, I was 32, 33 when I graduated, and I thought that was a little bit too long. My life plans, I wanted to have children as well. So at one point I came across this little thing on the wall that said, Canadian Dental Association, if you ever think about being a dentist, call us, and you have to have these tests before you admit to university. So I said, well, okay. First time I went around, I said, are you crazy? You want to be a dentist? Get out of here. So I went home, and the next day I went back to see that little sign on the wall, and it was like so attracting me. It was incredible. So I said, okay, it's stronger than me. So it was like, I don't like to use the word, but it was a calling. That sign on the wall called me to it. It attracted me like it was crazy. And I called the Canadian Dental Association, did the test, and been there since. Went straight from college to dentistry, didn't have to do a bachelor's degree before anything. So, but through dentistry, there was a frustration. It was definitely a frustration about what I was being taught in occlusion and night guards. It was so frustrating. The teachers would tell us, okay, you could do group function, you could do canine guidance, doesn't really matter. We don't know which is best, so do whatever you like. Then we'd have these bull and muddle laws to adjust the bite, buccal upper lower lingual, and that's how you adjust the bite. But it was so not precise, so unscientific compared to all the rest we were learning. It was so empirical and so, well, yeah, we'll try something. And when the patient's comfortable, you're done and it's good. It was like that. So there was no science to it. There was no thinking. There was no method that was going to be obviously uh, effective with the patients. And in night guards, they say, well, you can make a night guard. 50% of the time people wear them, 50% they don't. A lot of people don't think they're comfortable. People don't like them. So when you're told these things, but you look in the patient's mouth and you see all this destruction going on, all these signs of excessive forces, and you're kind of at a loss. I mean, you feel like you weren't trained to do the night guard properly, and actually you weren't. And I remember being frustrated. I've been teaching for the past 17 years, and students fresh out of dental school are telling me the same story. They were not trained, or they didn't feel trained well enough to be able to feel confident when delivering their night guards. And the American Dental Association did a survey a few years ago where they numbered it, and it's only 30% of night guards that are made that are actually worn. So 70% of them, the vast majority of patients that actually require a night guard, aren't even wearing them. So they're not protected, and all that's happening is that they're destroying their mouths just more and more and more. And so basically, after dental school, I did a residency program. And there I was exposed to two things that were very important to me. I was exposed to full mouth, crown, and bridge. I worked with a prosthodontist there and was taught hand in hand to do full mouth, crown, and bridge. And I also did about 30 orthognathic surgeries as an assistant to the surgeon. And so right out of dental school, I was trained to think system and not just teeth. So instead of being a dentist that would just look at a tooth and treat tooth this and tooth that and tooth this and tooth that and the guns around it, I started to think about how the system functioned and how to rehabilitate the system, and how everything had to function together, from the joints, the muscles, the teeth, and the periodontium. It was not just tooth and periodontium. It was joint, muscles, teeth, and periodontium. So the thought pattern was different, and that prepared me for what I'm doing now. And so I did I was practicing, and I practiced for a number of years. And then someday, um, uh, somebody came in and told me about the Dawson Center, and told me about, okay, this guy teaches occlusion. He'll really break it down to pieces for you and build it up in a way that's very logical, very effective. And I said, okay, let's go see him. And what we had been doing in my residency program was actually the same occlusion that Pete taught. So seated condyle, seated teeth, canine guidance. And that's how I had done my rehabs. And that's how, after surgery and ortho, we'd equilibrate the bites and we'd get to that. And then I did the curriculum at Dawson. That took 3 years to do that. And he introduced me to Mark Piper, who was a maxillofacial surgeon. And Dr. Piper, all he did in his practice was operate the joint. So like 90 or 95% of what he did was joint surgery, joint diagnosis and joint surgery. And what I gained from him was an in-depth knowledge of joint pathology and how joint pathology is. And when people talk about the TMJ, they usually talk about TMD, so temporomandibular disorders. But the expression temporomandibular disorder has no level of precision any higher than mouth disease. If you say mouth disease and temporomandibular disorder, you're at the same level of precision. You're not saying anything specific. You're saying, okay, there's something going on. So a displaced disc and a tumor are in the same, or just myofascial pain, they're all in the same thing, all in the same bin. And that's not how it's supposed to be. So Piper taught us to distinguish and differentiate and actually make a true diagnosis of what was going on. And we learned to separate pain from pathology. And they're totally two different entities that often coexist, but they're two different things. So pain comes for all sorts of reasons that may be a little bit sometimes not always obvious, and they go along with all sorts of other things going on in the body. But pathology is pathology. So my practice now for the past 30 years has been a lot of occlusion and temporomandibular joint pathology and treating pain. But that's a little bit, you treat pain different from pathology. And for the past 15 years, my practice has been strictly occlusion, joint, and rehab. And I get referrals. I get about 1,800 to 2,000 referrals per year because I'm known now in the province of Quebec. So basically that's, that pretty much answer your question? Did I miss this? Did I miss part of it?
No, that's a very thorough answer, but you raised an interesting point early on in that answer, and that is the purpose of an occlusal splint. Is it for protection, or is it for treatment, or is it for both? And even under treatment, you've got treatment of pathology or treatment of pain. So there's a number of uses for it. Does one size fit all, or do you need different splints for different ailments?
Okay. When I just gave the splint course yesterday and the day before, we use 7 or 10 different splints. There's one that is generally used and that's effective in 95 to 99% of cases. The others are designed for very specific usages. Now, if you're in general practice, you're going to use the splint we designed not 95 to 99% of the time. It's the basic, that question had so many sides to it. The question you just asked had so many sides to it. It was an excellent question. That was very brave. So let's try and separate that and answer correctly. A night guard only does one thing. It creates in the mouth a set of functioning conditions that are better than what the teeth create. Basically, it is like a crutch for a sprained ankle or a bad knee. The night guard, when it's well made, the ergonomics of the function will be better than with the teeth. So 99% of people have interferences and slides. When you have the night guard, you're supposed to adjust it to the point where there are no interferences or slides. So what happens is that the muscles function like they're supposed to. Like if we remind people of the elevator muscles, we have the masseter and the medial pterygoid and the temporalis. They're the elevator muscle. Then you have the opening muscles, the digastric and the lateral pterygoid. Lateral pterygoid does translation. We all remember that. Now, when you have interferences and slides, you have co-contraction of the elevators and the lateral pterygoid. And that's where the problems come in. That's where you get the pain in the muscles or the muscle fatigue or muscles using energy more than they would be supposed to. If you have an interference, I compare this, I explain this to the patients to help them understand in this way. If you have an interference from seated condyle to seated tooth position, or maximum intercuspation, however you call it, seated condyle to maximum intercuspation, if you have an interference in a slide, it is exactly, musculoskeletally, it is exactly like having a pebble in your shoe and twisting your foot to avoid the pebble. You're actually twisting your jaw position to avoid the interference. And your lateral pterygoid actually programs itself. It's called an engram, and the lateral pterygoid is programmed to bring your mandible a little bit forward out of the socket, a little bit, the joint out of the socket, just a little bit, teeth a little bit forward, mandible gets skewed, and you avoid that first interference and you close into maximum anticipation. So people think that's their bite, and they say, oh, my bite's good. But if you seat the condyles, you'll find those interferences. And those interferences actually create a situation where the muscles are not working in coordinated pairs, and the elevators have to work at the same time as the lateral pterygoid, which is an opening muscle. And if you look at the direction of forces, and I'm going into a little bit of physics here now, if you look at the direction of forces, the elevators push the condyle up into the socket as the lateral pterygoid pulls the condyle out of the socket. So when they have to co-contract, there's a tug of war going on. And the result is that is pushing the condyle against the posterior slope of the eminence. Now, if there's a disc interposed, not so bad for the joint. But when the disc is displaced, which is, and we can talk about that later, but discs are out of the socket, out of the joint, or displaced in over 90% of the population. And this was studied, and published in 2000 in a journal called the Angle Orthodontist. And this was studied and published using MRI and everything. So this is true diagnosis. And when the disc is out of place, then the situation in the joint isn't as good. And then you're actually hurting the joint. And as you hurt the joint, the condyle changes position, your interferences become worse. And then as the interferences become worse, then you may start not tolerating them. And that creates a situation where that's when the muscles start hurting or being tense. And when they're tense, or even if they're not tense and you're just functioning with a bite that's off, you're actually using excessive force, or either excessive or ill-directed forces. And that creates a lot of wear and tear in the mouth. So when you have interferences in slides, you may have pain, but that's going to happen in only 8 to 10% of people. You're going to have 92% of people that are going to have symptoms on the teeth, so signs that the dentist will see in the mouth. You will see fissures, you'll see cracks in teeth, you'll see wear, you'll see recession, abfraction, all sorts of signs you'll see from excessive loading on the teeth. And oftentimes dentists will look at these, the wear facets, and they'll tell the patient, well, I think you grind your teeth. And 99% of patients, well, that's right, I don't grind my teeth. I don't wake my spouse up. I sleep with my mouth open. I snore. I can't be grinding my teeth. And that closes the conversation. So if I can offer a pearl tonight, as dentists, we should not tell the patient what he's doing, because a lot of time they're not really bruxing. They're just functioning in an ill bite. And we should just look at the mouth. And when we see all this wear and destruction going on, just blatantly ask the patient, how did you destroy your mouth so bad? And shut up and wait for the answer. And then this patient will start thinking, say, well, it's either not important to them, that I don't care, or, okay, so do I grind my teeth? And then I always answer, well, I'm not with you at night, so I don't know if you grind your teeth or not. But what I see is wear and tear and destruction in your mouth. And let me show you. And then you show them with the 3D camera or the intraoral camera or whatever camera you have. You show them what's going on. So, in any case, the night guard comes in to alleviate the ill bite. So it reestablishes muscle function while it's in there. So we do a lot of night guards, but we also do bite adjustments, dental equilibration, which is such a simple procedure. When you learn it, you start from seated condyle, and you just adjust the bite so that you don't have any interferences left. And you have canine guidance after that, and you just become so comfortable. I mean, I haven't had a headache in 27 years, except after the second glass of wine. But If I don't go over 2 glasses of wine, I have not had a headache in 27 years because my temporalis muscle is calm now because it's not fighting against my lateral pterygoid. So what does the night guard do? What does it treat? Does it treat pain? Does it treat structures? Well, 5 years ago, I published a study where we took patients that were diagnosed with osteoarthritis of the condyle on MRI. So you see the cortical layer of the condyle that's perforated and it has osteoarthritis. It's obvious. The radiologist diagnosed it. And after 1 year of the splint, we re-MRI'd, and at least 50% of the patients saw total cortical layer reformation, and 80% of the patients saw at least stop, a total arrest of the osteoarthritis. And the other patients who had to be operated on, they either had to have their disc repositioned or the joint replaced, or a fat graft or something. So the night guard actually, because of the way it corrects the bite, well, it doesn't correct the bite, it compensates for the bite. I should say that well. So the night guard, when the night guard doesn't have any posterior interference, the muscles are not fighting, you're not getting the compression against the posterior slope, and you're just having a condyle that's a much happier camper. So the condyle isn't rammed into the posterior slope of the eminence so much anymore, so it has a chance to heal. The muscles stop co-contracting and fighting, so you're treating muscle tension, you're treating muscle pain, you're treating joint pain, you're treating joint pathology, and you're protecting the teeth. So to answer your question, you're doing it all. You're just doing it all. But again, in the course, I insist on this. The night guard is not what gets rid of the pain. There's no night guard that has ibuprofen that slowly leaks out. So the night guard doesn't get rid of the pain, like the crutch doesn't get rid of the pain in the leg or the ankle. The crutch gives you better functioning conditions for the body to heal or to adapt. So the night guard is the same. It puts in the mouth better functioning conditions while it's there so the body can heal and adapt. That's how it works. So, yeah, well, I guess I answered the question.
Yeah. How do we get this situation of how does a disc get displaced? And also you mentioned diagnosing with MRIs osteoarthritis in the disc, because you can have osteoarthritis without symptoms. So how do we protect how do we protect our patients and say you've got osteoarthritis? Obviously, this can lead to uh, a painful incident if it's not treated or arrested, as I know in other parts of my body, shoulders and thumbs. But how does somebody get a displaced disc in their jaw?
There's a study came out where they MRI'd babies, young babies before the age of 6 months. And this all happened. Well, let me tell the story. So, University of Alberta, Canada, there was an orthodontist there, Brian Nebba. Brian, as an orthodontist, at one point was being accused by his patients and by their parents of creating a situation with the bite after orthodontics or with the orthodontics, that after the orthodontics, like, typically ortho is done from 12 to 15, 16. That's typical. Then 16, 17, 18, headaches start, cracking joints, popping joints, all sorts of symptoms come on, pain, whatever. And so at one point he said, okay, I'm tired of being accused of creating these problems. Now, am I really creating them, or was the problem in the joint there before? So he got together with the radiologist at the Faculty of Dentistry, University of Alberta, who back then was David Hatcher. David Hatcher was an American that lived in Canada for a number of years and was associated with the Faculty of Dentistry in Alberta. So David said, well, we can MRI the joints. And we're now in the mid-90s. And MRI was available since 1988 for dentistry. So he said, well, we can MRI the joints and before ortho, and we can re-MRI them again after, and we can see if there's anything going on. We can see if the discs are in place or the discs are out of place. So lo and behold, that they published a study, and they took over 100, like 135 or 40, something like that, youngsters that needed orthodontics. And what they found out was that in boys from age 13 to 15, there's only 40% of the right side disc that are in place and only 36% of the left side disc that are in place. Basically, if you combine the two statistics, that means if you're a 13 to 15-year-old boy, you have an 80% chance of having at least one of the two discs out of place at age 13 to 15. If you're a girl, it is worse. It is like 72% displaced on one side and 77% displacement on the other. Combine the two statistics, if you're a 13 to 15-year-old girl in need of orthodontics, you have a 90% chance of having at least one of your two discs displaced. This was published in December 2000 in the Angle Orthodontist under Brian Nebbe. Now, that, and again, in 2000, this is 24 years ago. So we knew already back then that a lot of discs were displaced. So then the question came up, when do they displace, and what happens? Exactly your question. What happens for the disc to displace? So a number of years later, there was a study done on babies. Are they born that way, or does it happen? And so they MRI'd a bunch of children, a bunch of babies. All the discs were in place. All 100% of them, the discs were in position. So the conclusion is, through orthopedic principles, we know that ligaments do not get torn, and we all know that discs are held in place with ligaments, with the ligament structure. So the ligaments get torn through trauma, not through use. So basically, they eventually were able to relate childhood trauma to the displaced disc. Now, childhood trauma, we have to understand that I'm going to relate now to an article written by an anthropologist called Peter Unger. There's a journal called Scientific American. This journal has all sorts of scientific articles that the lay public can read. It's a high-end journal, but for everyone. And in April 1st of 2020, the Peter Unger, the anthropologist, wrote an article called "Why We Have So Many Problems with Our Teeth." And in the article, Mr. Unger wrote that our jaws started shrinking approximately 250 years ago. And that is anthropology. So this is anthropological knowledge. The human jaw started shrinking about 250 years ago. And he accused our poor chewing habits. So instead of chewing raw, hard, and dry, we now chew mushy, cooked, and soft, and wet or soft. So our chewing habits would have changed the growth and development of our jaws. So our bony and ligamentous and muscle structures have weakened in the past 250 years. So let's come back now to the childhood trauma. What appears to be is that the ligaments holding the disc onto the condyle have weakened or are weaker. Now, is that true of all other ligaments in the body? I don't know, but it's definitely true in the temporomandibular joint. So depending on your genetics, the blows you get to the back of the head or to the jaw, or actually even the whiplash, can tear your ligaments if your ligaments are not strong enough. And so it's a question of how strong are your ligaments versus the blows you get. Now, I had 4 children. 3 of them had displaced discs around age 5 or 6, and I can tell you which trauma tore the discs out in each of those. One of my boys grew to age 14 with absolutely no disc displacement, beautifully developed jaws, started doing, and I had an MRI of the perfect joint. And then he started doing karate, did his black belt, got a kick to the jaw, and his midline shifted on that day. As the ligaments were torn, he said, "Dad, I hurt my jaw joint." I said, "Oh no, close your teeth." Midline was shifted to the hurt side. So as the ligaments were torn by the blow, the disc slid forward, jaw skewed to his right side, if I remember correctly, and the midline was skewed to the right side. And it happens with trauma. Now, all children play and fall and knock ourselves. I had 4 kids, and I stopped using the word trauma with the parents, because if you tell a parent that their kid had trauma, they go, yeah, exactly. They go crazy. They think you're accusing them of beating your kids or something. No. I always say, yes, it happens when children play and fall and knock ourselves, So yeah. This was an active kid and he fell all the time. And then you get the true stories. The youngest patient I palpated a click was 16 months old. He was just playing on his hands and knees, fell, hit his chin, and at the neck, he didn't even cry or anything. Mother just picked him up and said, "Okay, keep on playing." And at the next meal at lunchtime, she said, "What's that noise?" And she could hear the click. And the disc was displaced just by a simple fall from walking on your hands and knees. So it happens when you tumble downstairs. It happens when you play at the park. It happens when you have a whiplash kind of thing. It happens when you fall off your bike. It happens when you're playing with friends and you get and you're just, play fighting and you get an elbow or a shoulder blow or a ball or a baseball, a football, a soccer ball, what have you, rugby ball, whatever it is that hits you can actually tear your joint, tear your ligaments. So that is the conclusion we have come to, that it is childhood trauma or trauma at any age, actually. But in childhood, again, there's another thing also going on at the same time. The temporomandibular joint is the least developed joint in the body at birth. At birth, everything is cartilage. It's not osseous. It's not bone. It is cartilage. We know that the head, there's the I don't know how you call it in English. We said the fontanella in French. So the skull is not hard at birth to be able to be born. Well, this has to be soft as well because it has to squish for us to be able to be born. So the temporomandibular joint is not, the fossa is not ossified and there's no eminence. It's flat. So all of these structures are very fragile, and babies, we all know babies want to bite everything. Babies want to chew. Well, it's in their program because that's how the ossification happens. That's how they get their structures strong. And, so we'd have to have kids eat hard things, but we give them mush because we're afraid they're going to choke. And there's this thing now in North America where we're starting, my daughter has 3 little boys and she's giving them hard food again. We're back to having babies chew carrots and chew hard things to get the jaws a little bit stronger again, to do a little bit of prevention, hoping the blows won't have so much effect because their structures will be stronger. So that's how that happens. And there was another part to your question. I forgot the other part. So
No, that's it. But we're talking about the osteoarthritis and pre-diagnosing it. And though you diagnose it and then you treat it in case it's going to hurt, or do you wait till it becomes painful and then it's a tough road back from
I think that was so easy to answer, David. Thank you for asking that question. That is such a great question because that's what people think. David, as a dentist, did you wait till decay hurt before you treated it?
Never.
Did you wait till the gums were grayish and smelled crazily bad before you before you did anything to the gums? Or did you do something early on? Did you learn to be preventive? Of course.
So if you diagnose the osteoarthritis, is that just part of a routine diagnosis?
Yes, of course. Most of it you can see on the panoramic image. I mean, I gave a lecture for a group called Bite Effects. I gave a lecture for them last week where I showed 23 cases of just using this. I mean, you could tell me in Australia, is taking a panoramic image a something necessary? Is it routinely done? Is it routinely done? Like in Canada, we typically do it every 5 years. Like in Australia and elsewhere in the world, do people routinely take panoramic images for their patients?
I would say they should be taking them in my opinion, they should be taking them more frequently than every 5 years. That's like asking how often do you clean your house? Yeah, some people's wives clean their house daily, others clean them monthly, others clean them never. So it,
Well, I was told that in some areas of the world, taking a panoramic image is not something that's routinely done. So, anyways, so I said, okay, let's do this lecture. I've been giving lectures for Bite Effects for the past 10 years. I'm doing webinars for them for the past 10 years. And we had never done the panoramic image. And we did, in 45 minutes, I presented 23 cases where you could obviously see on the panoramic image there was something wrong with the joint. Now, the panoramic image is not very specific for the joint. It's a poor image for the joint. But if you see something on the panoramic image, there's already something pretty strong going on. If the condyle's lacking volume on the panoramic image, it's because the condyle is at least 30% smaller than it should be. So anyways, with the osteoarthritis, now there's all sorts of ways, and we're not going to go through that tonight because it would be way too long. We'd spend the next 3 days. But if you suspect anything going on within the joint, treat right away. I mean, put the night guard in. And you said something important. Pain happens only in 8 to 12% of cases if you have osteoarthritis in the joint. This is orthopedic literature. Bad knee with osteoarthritis, you'll have pain. 90% of people that have osteoarthritis of the knee or the hip don't know about it because it doesn't hurt. They know about it when it hurts, because you don't take x-rays of your knee and hips when you go to the doctor every year. They'll ask you how you are. If you're limping or if you have pain, then they'll take the images. And oftentimes it is already very late and far down in the process. Now, there are ways to find out if the discs are displaced and you're having problems with the joint. Panoramic image is the basic diagnostic tool. When you're into these things like I am, I can look at the way your jaws are developed, the way your jaws are functioning, and look at the way the teeth are aligned and your midlines and all sorts of things that you have to combine together. And I can pretty much have a good idea of how, in what state your joints are. Again, the splint course I gave this weekend, general dentists walking in, or a bunch of them in the room, and from 8 o'clock to 2 o'clock in the afternoon, I tell them about the joint and how to look at the joint and all sorts of things. And at 2 o'clock in the afternoon, they can look at a face and know if the condyles are good or bad. They'll have a general idea if the joints are good or bad. I mean, you can't do a diagnosis looking at the face, but you can have a general idea if the joint is good or if the joint is bad, looking at the bite, looking at the face. So we have, when you learn about these things, it doesn't take so long to learn about all of this. I mean, just a good education, well-planned education course where you will learn to see how things are going on. And as soon as you see anything wrong or on the panoramic image or in the mouth, then you have to start investigating. And by investigating, then you'll find out. And if you have any osteoarthritis or even just a displaced disc, because all of this, anything going on in the joint affects your bite. Like if the door hinges go crooked or go bad, the door is not going to close properly. And it's the same in the mouth. If the hinges are bad, you're not going to have a good bite. You're going to have a bite that's offset, or you're going to have interferences, or something's going to be going on, and then you're going to have destruction in the mouth.
Yeah, we could talk for hours just on diagnosis, and you've raised some questions there for me, because I know in my practice I went from an OPG machine to a cone beam, and then the cone beam was after I sold my practice, the owners took the cone beam out and said they're going to give me another OPG machine. I said, as well not take it out of the plastic, because I didn't feel that it gave the diagnosis that I needed for the things that I was doing that the cone beam did, because the cone beam gave you sections, whereas as you mentioned, on a OPG, the distance of the beam from the joint on one side to the other can give completely different images, even though it's not really. You really do need the slices.
Yes.
But moving on from the diagnosis, because I want to get to the treatments that we were talking about and you were talking about as well. You have a splint that works in 95 to 99% of cases. How did you come across that splint, and why is it so much better than other splints out there today?
Okay. Thank you. Excellent question. Okay. Basically, for a number of years, we were doing the splint that's most recommended now. It's a flat plane splint, flat plane in the front, no wrap, flat plane splint in the front, flat, full coverage, flat plane, no indentations. And basically what's taught in universities now is to seat the condyle and have total contact without interferences. So all the teeth should contact together at the same time. From there, you should have canine guidance and incisal guidance going forward. This is what is taught. Not very well taught on how to seat the condyle. That's very poorly taught. But if you adjust your night guard well, at least you come to equal contact everywhere, canine guidance and incisal guidance. Now, at the Dawson Center and at Pankey and other American institutes, they will teach you how to bimanually manipulate the jaw to seat the condyles. Now, I know in different universities, they'll tell you to send your head back or put your tongue back in your throat. And those methods are very, very imprecise to seat the condyles. The best method to seat the condyles, the best method I've found, I've been looking around for 30 years, is with what is called a leaf gauge. So the leaf gauge is excellent, and when well used, you will seat the condyles very properly, very well seated, and from there you take your bite to send your impressions to the lab, and then the night guard will come back without any interferences in the back or with minor adjustments to do. Now, I'd been doing these night guards for a number of years with a high success rate. 75% of my patients were out of muscle tension, and then out of pain, and then the joints were getting better. And I had, 75% is a high success rate. So we were happy with what we were doing. And at one point, a young lady in her 20s came in and said, "Your night guard's giving me headaches." I was like, "What?" No, I did research with Montreal Migraine Clinic. I was getting rid of headaches. I'm not creating headaches. I'm getting rid of headaches. Hey, and I'm good at this. So you're wrong. I'm not giving you headaches. And she said, "Well, since I've been wearing this, I got headaches." So scratch your head. I said, "Okay, maybe my adjustment's not perfect. So let me check it." So seat the condyles, readjust the night guard, make it as perfect as I can. And I did this 3 times. Actually, I did it twice. I redid it twice. And on the 3rd appointment where she came in saying, "This thing is giving me headaches," I went, okay, something's wrong. Okay. Posterior teeth, I don't know if everybody knows this, but the posterior teeth have the pressure sensors that turn the muscles on. If we all do this very simple test of putting our hands on our masseters and temporalis, and we clench our back teeth, we will feel the bulging of those muscles. Now, from there, go to an edge-to-edge position and try to make your muscles bulge. Your temporalis will not bulge. Your masseter will bulge a little bit. Now, this is a physiologic response. This was published in 1983 in the Journal of Prosthetic Dentistry by Williamson and Lundquist. This is the fact that the back teeth, the posteriors, molars and premolars, have the pressure sensors that turn the chewing muscles on. If the posterior teeth are not touching, you cannot voluntarily contract these muscles to 100%. You can contract to 25 to 30%. And the opposite, if these teeth are touching, like if you have an interference, the muscles want to turn on. The brain thinks there's food between the teeth and it wants to clench. So if you have a night guard that touches a little bit too much in the back, actually you're creating a response where the brain thinks it has a piece of gum or something to chew during the night, and it will contract and it will chew on that night guard. And this lady was very, very sensitive to any posterior contact. And a lot of patients have a little bit of adaptability. So you can leave a little bit of contact and they won't react too much. But this lady was very, very acute in this, very, very sensitive. So I took all the contacts away from the posterior teeth. I said, okay, the hell with it. Let's do this. So I took all the contacts away. And she came back after a month and said, I don't have headaches anymore. And I went, oh my God, okay, what happened here? What did I do? What did I do right? What did I do wrong? And then I said, well, okay, well, I'm happy for you, but now I have a problem. I have a problem that I found something and I'm not sure what to do with this. So I said, okay, how much space do I have to leave between the opposing teeth and the guard? Because I don't want supereruption to happen. Like I don't want all these teeth erupting, and I don't want to have an open bite caused by what I'm doing. So, okay, what am I going to do here? So after a while of trial and error, I came to this conclusion. If I was to leave 20 microns between the night guard and the teeth, and I measured so using a paper called AccuFilm. So the AccuFilm paper it's a plastic film. I don't know if everybody knows that, but in America, everybody knows it. And it's just 20 microns. So I have the patient retrude and clench. And the night guard and the teeth have to be just enough so that the AccuFilm will barely slide through. Another thicker paper has to tear, but the AccuFilm has to just barely slide through. So I know that if they clench during the night, they're not going to be having any contact. And also, if they have 20 microns of eruption, of supereruption, I don't really mind because I'm going to be doing the bite adjustment after that. And taking away 20 microns is really not a problem. And even if you had 20 microns of supereruption in the back, you have an open bite of 40 or 50 microns in the front. So again, you can compensate for that by the bite adjustment. So it's not a problem. It's a non-problem. So I took care of everything by doing it that way. And so I started adjusting all my night guards that way. And the success rate skyrocketed. It went from 75% to 94%. The night guards I'm doing now, 94% of patients have some type of relaxation and relief of their symptoms. Now we're talking about symptomatic patients. So, and we're about to publish a study with 1,500 patients. Now, this is the largest study, to my knowledge, this is the largest study ever done on night guards. We've been keeping statistics for years, and we're about to publish. We're writing it up, soon ready to go to see if they'll want to publish. But the journal's already published us before, so they'll hopefully want to publish us again. And 1,500 cases of night guards and bite adjustments and the effect on the muscle tension and the pain on headaches, jaw pain, joint pain, and neck stiffness and pain. And the statistics are incredible. It's 94% of patients now that have a reduction and this is measured. It's not just off the top of the head. Are your patients good? Yeah, all my patients are good. No. This is measured. Every single patient did an analog scale before and after, and as we go. So this is measured well, and we have these incredible results. Now, we have a subset of patients. There's 5 to 6% of patients that have absolutely no effect, and these are typically high-strung patients, high levels of stress, and they get Botox or they get other things and psychological care and all sorts of things. But the majority of patients have some type of relaxation, and out of the 94%, 14% have only a little bit of relaxation of the muscles, but 80% have more than 75% of the muscle tension is reduced and the pain is reduced. And I've been in the field for the past 30 years. I've tried at least 25 to 30 different types of night guards. I've been around the world looking for everything. And this is what I've found that is by far the best.
Excellent result. But you stumbled across it. That's the fascinating part.
Isn't that how research is often done? That you stumble onto something, you're not even looking for it, and you stumble onto it, and it's like, oh, okay, just open your eyes. You have to open your eyes and see it, but yeah.
That's how the Post-it note was discovered. Guy was trying to work out the world's strongest glue. Found this one kept sticking all the time, but it wasn't. Anyway, Alain, you've built a private practice. Basically, you don't drill decay out of teeth anymore. You are a dentist specializing in TMJ and night guards and splints. How? I guess the point is that dental schools don't teach this as being a major cause of pathology, but you recently did a presentation for Advance Me where the heading was why all your patients need a splint. Why everybody needs a splint. What are dentists missing if they're not diagnosing these problems?
Well, I think from the experience of the past 17 years teaching, the dentist, I think, and what they've told me is that they don't feel confident delivering their night guards because they don't feel confident they can do it right. Because again, the American Dental Association did this study where they said that only 30% of night guards are actually worn, 70% are not. Now, most dentists want to do proper care for their patients. And if you're going to charge a patient a certain amount of money to do a night guard or to do whatever procedure, you want that procedure to be effective. You want it to be good. You want it to be well done, and you want it to be effective for the patient. And if in your practice, if you've been practicing, let's say for 10 years, and you actually know that, 70% of the night guards you've made are in the drawer and they're not being used. I mean, what's the use of talking about it, right? I mean, people are not wearing them. So you just talk to the patients that have teeth worn down to the gum line, and they need it, and then they want it. Or if they're painful, okay, you'll do it, and then they'll wear it with so efficiency. But that I think is the main reason. They're not the education they have doesn't get them confident enough and effective enough at making the guards that are effective and that are worn. Now, you should see the number of night guards. I do a lot of new night guards, but I also take the night guards the patients walk in with and just readjust them. All I do is readjust the guard so that there's no posterior interference and no posterior contact when the canals are seated. And it's a world of difference. And this subset of patient is in the study. Same level of effectiveness. Whether I make a new night guard, a bite adjustment, or take an old night guard that was not effective and just adjust it, you have the same level of effectiveness. 94% of people stop having tension and pain. So, dentists, I think, are just, and I don't want to say they're undertrained. Probably they are, because even the teachers probably don't understand the functioning of the night guard well enough. But I don't want to accuse the teachers. But the end result is that the end result is that dentists feel undertrained because the result they have with their patients isn't up to par with all the rest we do. Do an endo, you have a 98% success rate. Do a filling, you have a 99.5 success rate. So we're used to these very, very high success rates with almost everything we do. So when it comes to the night guard, we're disappointed. We feel disappointed. We feel guilty. We feel all sorts of things because patients are not wearing them. We're charging them and they're not wearing them. And so we sort of brush it under the carpet and we push it under the carpet and brush it away, and we don't want to think about it. And because we don't want to think about it, we see these destructions in the mouth. Like, listen, David, remember your patients. Tell me seriously, how many of your patients, what's the percentage of patients you had that did not have any sign of wear and tear in their mouth, of premature, we call it premature aging. So no wear facets. No, yeah, you're smiling. So yeah,
None.
none. Okay. How many patients? Okay, there's once in a while you'll meet the exception. Once in a while you'll see this exceptionally pure, perfect, and beautiful mouth, and we're all happy for the patient. Great, get out of here if you're frustrating me. But almost everyone. So everybody has a slip and a slide. Everybody has a little bit of a poor bite. Everybody has excessive forces or ill-directed forces. It's not just excessive, it's ill-directed. If the wheels of your car are misaligned, you're going to wear your teeth crooked. Your teeth, sorry. You're going to wear your tires crooked, even though you're going speed. You're following the speed limit. It's not necessarily because you're going too fast. It's because it's the tires, the wheels are not aligned well. Same thing here. Doesn't mean you're grinding. It means you're not aligned well. You're not functioning like you're supposed to. You're offset and you're creating wear and tear in patterns that are not natural. So the main reason is that they have a lack of confidence. And because what they've been doing is not effective and not worn, like, we do fillings because they're effective and they work. If we had a method to do night guards that would work, we'd probably do a lot more. And that's why I've been teaching for the past 17 years. And at home in the province of Quebec, now that I've taught for 17 years, I taught 1,000 to 1,000 dentists, like little groups of 10, 15, and 20. 50% of all night guards made in the province of Quebec are now, they call them Aubé splints, or what they're called ICO splints now. But in French, in the province of Quebec, we say Aubé splint, but elsewhere in Canada and the US, we call them ICO splints because they're effective. Listen, at home, they call them the magical splints. I don't like that word because they're not magical. But dentists call it, I do the Aubé splints. They're magical. No, they're not. But they're very effective. Yes, they're highly effective. Yes.
Alain, we're getting towards the end of our time. Let's talk very briefly. In the education or lack of education out there on splints and night guards, there's also the ability of giving patients appliances that help them with their sleep, their airways as well. How do we go? And this is, I think, one of the things that inexperienced dentists are cautious of because they or weary of because they don't really know if they're going to end up a rabbit burrow, of where do I end the treatment? Or all of a sudden I might be trying to fix somebody's sleep and their airways, and I've had no education in that because they've never been given that education. How do we stop the misdiagnosis in those sort of situations where an appliance is helpful in fixing a bigger problem?
Well, it's education. The answer to that is education. You have, like, night guards. Now, again, joint pathology leads to poor airway. There's a book, the first book on joint pathology that came out. The first edition was published in 2016, called Specialty Imaging Temporomandibular Joint. That book is revised now and thicker now. It's called Specialty Imaging, Temporomandibular Joint and Sleep Disordered Breathing. As the joint does, if the joint, another thing, when the disc displaces, the condyle doesn't grow to its full genetically planned potential. That creates a class 2-ish bite. Now, that creates a small jaw, smaller lower jaw, retruded lower jaw, that impinges on the airway. So one of the reasons for poor airways is a short lower jaw. So one of the reasons for a poor airway is either subgrowth of the condyle or osteoarthritic damage with time, where the mandible retruded with time because of the osteoarthritic process. Now, in my practice, I do not treat airway problems directly. I don't do mandibular NADs, mandibular advancement appliances. I don't do those. They're not what I do. I don't have the time to do them. These appliances render fantastic services to a lot of people. I've taken the courses because I want to understand the process. But I don't do these appliances. I don't have the time. However, you have to be careful. Right now, I am treating 3 patients. 2 of those are dentists. They had used the mandibular advancement devices, and they're having worse condylar issues, severe osteoarthritic damage, because the disc wasn't there anymore. If you advance the mandible with an appliance and the disc is interposed, you'll be fine in most cases. But if the disc is totally displaced and a non-reducing disc, all you're doing is you're taking that condyle, pushing it against the slope of the eminence and rubbing it in there. And you're potentially creating damage. And right now, again, I'm treating 3 cases, 2 dentists that have worn these appliances for years and now are suffering like crazy, and we're looking at joint replacements. Now, if you treat early with the night guard, you may prevent some of these problems. And for subgrowth, then you can treat with dentofacial orthopedics. But we can have a whole other conversation, another hour conversation just on that subject. But basically, using my type of night guard, a lot of patients will feel better and sleep better. But it's not because we open the airway. It's because they're having less activity during the nighttime. If you have severe airway issues, you need to have either the CPAP or the mandibular advancement device, being careful what's going on in the joint, or you get the double jaw surgery and you get your airway fixed and opened. Now, so I don't treat these patients, but I refer at least 20% of my patients for sleep tests. At least 20% of my patients get referred for a sleep test because they have signs and symptoms of possible sleep apnea. So we take care of the airway because, and again, you said it, it's education. You have to educate yourself. You have to go to the courses on airway. You have to educate yourself. You have to find out how these things are made and why they are. You have to educate yourself in joint pathology to find out when not to make those appliances. In my view, I'm going to say something that this may shock people, but I'm going to say it anyways. This may shock dentists. But in the world we are in now, with all the relationships between our structures we treat and total body health, I'm almost to the point where I'm starting to think that dentistry should be a specialty of medicine. We should almost all be doctors before and become dentists after. There's just so many relationships to what's happening in the mouth and what's happening. I graduated in 1984. We were dentists back then. We didn't the relationship between teeth and the rest of the body it didn't even exist. So we treated teeth. We're dental surgeons and we treated teeth, and that was our job. Today, it's different. I mean, you still can drill, fill, and build and do a lot of decay and taking care of that. But the association between gum disease and heart disease and airway and the rest of the body and oral cancer and, and the rest of the body and all sorts of things happening, we need to educate ourselves. And it's not like when I came out of dentistry. When I came out of dentistry, they told us, you're just fresh out of your course. You're 5 years ahead of anyone that's out. Today, it's the opposite. You walk out of dentistry with a diploma which is a license to learn. You walk out with basic knowledge, and it's just a license to learn more. And we need, and okay, let's get even down to the nitty gritty. Accountants will tell you, the more a dentist spends in education, continuing education, the more they build and the more profit they make. If you educate yourself, you're going to diagnose more, do more, be more confident. That's going to show with your patients, and the patients will seek you and they will refer to you. If you don't do much and you just little things, you can do, like I have a good dentist friend. She says, I do easy dentistry, but she's educated and she refers. She sees the problems. She refers the problems. She only does simple treatment. Says, I want to do easy dentistry. I'm at a point in my life. She's in her end of the 40s, early 50s. She said, I've done it all. Okay, I'm back down to basics. I want to do easy dentistry, slow cruising for the rest of my career. But she educates herself anyways. And she recognizes the problems and refers. That's intelligent. That doing it your way, keeping it simple, keeping your stress levels low, but referring and helping your patients.
Yeah, there's a whole big world out there that we could continue talking about, Alain, but we've come to the end of our time. I appreciate you sharing your Sunday evening with us here, and thank you for being a guest on the Ultimate Dental Podcast. If somebody wants to get in touch with you, what's the best way? How can they get in touch with you?
The email. The best way is through email. Through email or through you, whatever. You can give my coordinates, no problem. So I won't say it here, but you could probably send my email to whoever wants it, and or through the online courses on startingwiththebasics.com.
All right. Excellent. Thank you very much again, Alain. And you certainly opened my eyes after being in retirement for 7 years. There's still so much more there that I can look with my clients in terms of not ignoring this important part of dentistry, that you've got to be able to help your patients, even just keep them pain-free, keep them stress-free, because so much goes on in the mouth, and a lot of dentists, as you said, they just ignore that and hope that it's not going to be a problem for their patients, and often it ends up being that way. Thanks for being on the Ultimate Dental Podcast.
Thank you very much for the invitation, David. Thank you very, very much.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being a part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favorite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth, your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, keep smiling, keep striving, and keep on tuning in to the Ultimate Dental Podcast.